Although QAPI has been added to the upcoming COP changes being implemented by CMS, this likely is not a completely foreign topic to most of you. CMS has simply taken the step of adding QAPI to the long-standing regulation of OB/QI. QAPI is likely a familiar term as it's a requirement of many of the accrediting bodies. QAPI is designed to encourage agencies to strive to improve. Obviously, to improve, you need to make changes. The tools in HomeHealthGold are designed to not only give you clear access to your measurable data, but to also indicate where within your organization you can best focus your efforts in order to change. I'll show you some concrete examples in just a few minutes, but please remember that these are just examples and the CMS has designed QAPI to be very flexible as they want the changes you make to be specific and meaningful to your agency. No two QAPI programs need to look alike. You can choose to work on bettering the hospitalization rate of your COPD patients, whereas another agency may choose to focus on improving their timely initiation of care. Each of these would fulfill the mandate. CMS states, we want home health agencies to utilize maximum flexibility in their approach to the quality assessment and performance improvement program. Flexibility is provided to the home health agencies to ensure that each program reflects the scope of its services. Performance improvement projects must reflect the home health agency's scope, complexity, and past performance. It must be data-driven and affect patient outcomes, patient safety, and quality of care. As I mentioned, QAPI or any improvement project is not a new concept to most of you and can be broken down to a few manageable steps. The first of these steps is to use your data to determine where to focus your QAPI efforts. If we are considering a measure such as improvement in ambulation, this can be done a few ways in HomeHealthGold, such as from a dashboard graph, from Home Health Compare, or from Measure for Success. Timely initiation of care and many others that may be beneficial for you to be working on can also be found in these locations. Also mentioned in the QAPI regulations was the encouragement to focus on improving performance related to patients at high risk for hospitalization and infection. To aid you in identifying and measuring success in avoiding hospitalization and infection with these patients, we have added a new high-risk feature to the HomeHealthGold dashboard. We will discuss this in more detail in some upcoming examples. The next step is to identify why the performance is below your expectations and develop a plan to make changes. These corrective actions could include, but certainly not limited to, focused OASIS education, clinical skill development, amending current visit practices, and increased supervision. The unique ability of HomeHealthGold that allows you to study the components of your agency compared to one another, teams compared to teams or case managers compared to case managers, can make this task exponentially easier. Our Measure for Success and Golden Opportunities can quickly show you which parts of your agency are not performing as well as their peers. Focusing your changes or improvement efforts on this section of the agency is not only the quickest path to success, but also the least disruptive approach to take. Working specifically with the teams or case managers who are underperforming will allow the satisfactory teams or clinicians to continue with their successful routines. The patient drill-down detail and Measure for Success and Golden Opportunities will give insight not only to the lesser performing components of your operation, but will allow you laser focus on the charts where there are issues. An example of this could be poor improvement in transferring. Are the patients on this team truly not improving in a similar manner to the rest of the agency, or is there possible need for OASIS education regarding how to answer this question more accurately at start of care? You will need to do detailed chart and OASIS reviews to understand the practices and possible shortcomings of your staff, but our tools will lead you to the charts that need your attention. Once these deficiencies are identified, a corrective plan needs to be developed and implemented in order for them to amend their previous patterns. Again, we simply need to make some positive changes. This may be as simple as focused OASIS education on items that are misunderstood, or may be much more complex and require increased supervision and joint visits with staff to help them unlearn unwanted behaviors. Once you have implemented or attempted to implement changes within your organization, you must allow some time to pass before tackling the next step. This step is to remeasure your objective information to see if your changes were indeed effective. As the data in HomeHealthGold is continually updated, there's no need to wait for changes on the CMS website or your CASPR report. The monitoring can be done in a much timelier manner. If the answer is yes and you are trending in a positive direction, that's wonderful. Feel free to take a momentary deep breath and pat each other on the back. If not, it's time to rethink the problem and seek an alternate solution to show improvement. If indeed your efforts were successful, your work is not done. That's why the congratulatory deep breath was short. CMS states that agencies must track their performance to assure that improvements are sustained over time. So don't take your eye off the ball. Continue to monitor to assure there is lasting improvement. Also, if you are satisfied with your results, it's time to find a new measure or measures that need your attention. Remember, this is not a one-time exercise. Let's take a look at HomeHealthGold software for a couple of examples. Here is an image of a HomeHealthGold dashboard taken in July. Because of our lack in improvement over time, I've chosen to focus on improvement in pain interfering with activity. As we all understand, this is an important measure not only for our home health compare scores, but also for our 5-star and value-based purchasing measures. As an agency, we seem to only be able to get 60% or so of our patients better with this measure, and our governing body believes that we can affect change and perform better. Drilling down on the July data point will reveal the detail of which patients deteriorated, improved, and stabilized. But I want more information about where I need to work in order to show change, so I'm going to use the Measure for Success tool. From here, I have chosen to compare the performance of my teams on the 5-star scale in order to find more clarity. Here I can readily see that although my agency is showing improvement in 61% of the episodes, we are being buoyed by the performance of Central, Clearbrook, and Ridgeville, whereas the performance in the remaining teams, particularly Crooked Creek, Central 2, and 3 Thieves, is significantly lower. Drilling down on the blue number with Crooked Creek will shed light on which patients have not improved and will help to focus our chart review and teaching process. The identification of which clinician performed the assessments is also potentially key to understanding the lack of improvement. Continuing to the next step of this tool and selecting golden opportunities will show us if we could raise performance of our weaker teams to even the 40th percentile, we would show an overall improvement of nearly 4% on this measure, even without affecting any changes with our superior or middle performing teams. Perhaps that's a reasonable goal for our agency at this time. We can also continue to achieve this line of thinking by determining which case managers need to show change. I have now built my dashboard for a 12-month period as to have access to more data on my case managers and have built the dashboard to focus specifically on my Crooked Creek team. Now, when I choose Measure for Success and select the option of comparing case managers to one another, my data will be focused only on those case managers with the patients on the Crooked Creek team. Since I want to be able to study the case managers with more activity and therefore more impact on my agency performance, I'm going to now select the Golden Opportunities option. At this point, I have made a series of selections to focus on my area of interest. First of all, I have set the top spinner to the 45th percentile. This is essentially drawing a line in my list of case managers and determining those who fall below this threshold. Next, I have chosen to disregard case managers who have had fewer than 5 patients. Then, I highlighted the pain interfering with activity measure. From here, I can also see if I were able to improve the performance of these lower performing case managers to the level of the 45th percentile, what impact that would have on the scores for this team. Now in the box on the right, I can see my low performers and can drill down on any clinician to study the patients where they were the case manager. Here are Joan's patients, and we can see we are only getting credit for one of the 6 for showing an improvement in their pain interfering with activity measure. It is quite likely chart reviews and staff interviews would reveal there are indeed pain issues being dealt with and improvement being made, but likely the initial assessment for M1242 are painting a false impression that there are no pain issues and therefore we're not able to document subsequent improvement over the period these patients are in our care. Given that fact, there is opportunity for our field staff to gain a clearer understanding of this question to provide a more accurate starting point when completing the start of care or resumption of care oasis. Focusing our improvement efforts on those specific teams and assessing clinicians is our best path to change and measurable improvement. Fast forwarding to a more current graph to review the status of our improvement in pain, we can quickly see our graph is trending in a positive direction, and we have a higher percentage of patients showing improvement. 73% for August, and now at 81% to this point in September, far exceeding our goal. Remember, we can't rest on our laurels and must continue to monitor our results. With an eye towards QAPI, late in the summer of 2017, we added a new high-risk report to the HomeHealthGold dashboard. This was done in order to provide agencies with easy access to high-risk patients that CMS mentioned in the COPs. The focus with high-risk patients is twofold: to prevent hospitalization as well as to prevent infection. Using this data source for your QAPI efforts will be quite simple and effective. Let's start with the dashboard focused on June and see what our high-risk report reveals. Due to our hospitalization rate, first, I will select the Include All option. This selection will show, for the starts of care and resumptions of care that were completed in June, those which deemed to be at high risk. I have chosen to focus on patients that are high risk because of their dyspnea, but as you can see, there are many other measures I could have selected. In this example, we have 68 patients with risks due to shortness of breath identified. If we were to then modify our selections to focus on only those where the start of care or resumption of care was followed by a transfer to the hospital, we can now see that 29 patients meet this criteria. This would be a 43% hospitalization rate for those high-risk patients. We need to take a closer look at the 29 patients and can do so by drilling down on the blue number to see if their hospitalization was indeed related to respiratory problems and truly count against us. Further chart review would be necessary to see what teaching or practice modifications may be needed to lessen this occurrence. Perhaps there needs to be more effort to front-load visits at the beginning of the episode, involve therapy sooner or more frequently, or provide teaching that a call to the agency in the middle of the night is preferable in many situations rather than a visit to emergency services. Building a dashboard for a specific team or case manager would also be an effective option to show where changes and improvements need to be made. Once the teaching and practice modifications have been implemented and some time has lapsed, it's time to remeasure. If we fast forward to a dashboard for August and repeat our steps in the high-risk report, we can see we had 61 patients at high risk for hospitalization due to shortness of breath. And of that population, only 9 were hospitalized. The data shows that we are definitely moving in the right direction and our practice changes are effective. Remember, we are never done. We must continue to monitor and measure our progress. One other important phase of your QAPI program is the documentation. It wouldn't be healthcare if we didn't need to be mindful of the documentation. Like the entire QAPI program, the documentation can be individualized by each agency, but I would encourage you to consider having some of these components. 1. Identify areas of weakness. 2. Performance improvement activities implemented to achieve the desired change. 3. Time frame for implementation. 4. How success or progress will be tracked and measured. And 5. Follow up on data collection and progress towards desired change. A couple of final points. Although not specifically stated in the QAPI regulations, it is implied that agencies will be working on several improvement projects concurrently. Historically, agencies developed a professional advisory committee that oversaw their QAPI program. That is no longer the case. Now the agency's governing body, board of directors, etc., is directly responsible for QAPI. I hope this has been helpful information on how Home Health Gold can be of assistance in your QAPI program. If you are a current user of Home Health Gold and have any questions, please contact Mike at homehealthgold.com or Rhonda at homehealthgold.com. If you are not currently using Home Health Gold but would like to learn more, please contact us at info@homehealthgold.com or telephone 207-872-4544. Thank you for your time.